for those of us in the East Coast. Nice to have you all. My name is Anissa Mitchell. I'm Vice President of Programs here at Parkinson Movement Disorders Alliance. And we are going to be talking today about hallucinations and delusions in Parkinson's disease with Dr. Shprecher. He is a movement disorders director at Banner Sun Health Research Institute in Sun City, Arizona, and he's also clinical associate professor with the University of Arizona in Phoenix. Before we get started on this topic, I'm just going to let you know that we're going to keep you muted today. We do have quite a number of people that registered for this program, but I do want to encourage you to ask questions. So if you want to ask your questions in the chat feature, if you scroll at the bottom and enable your little chat box, you are free to ask questions throughout. And then I will go through them and we'll ask them to Dr. Shprecher as we go along. So Dr. Shprecher, welcome and thank you for joining us today.
All right, thanks for having me. And I see we've got a really good turnout today already. Now, one thing I want to point out, when I was preparing this talk, I looked back and the original slide deck that I put together was actually to raise awareness about a study of a medication that was being developed for this problem. And I put this slide deck together back in 2011. And I'm pleased to tell you there actually has been some progress since then. And I'll really try to highlight what the progress has been over the last nearly 10 years in that direction, but also some of the challenges that still remain. One of the important challenges up front is we as doctors need to do a better job of speaking in terms that our patients and caregivers understand. So you'll often hear doctors use this term psychosis or Parkinson's disease psychosis, but what it really means is hallucinations and delusions. And when we talk about the problem or the treatment options, that's really what we're referring to, is either hallucinations or delusions. And hallucinations are a problem where somebody with any of their five senses can experience something that an individual who's healthy without any neurological problem would not perceive. And so the most common that we see in Parkinson's disease is the visual type, where people may see something that's not really there, but it can involve any of the five senses. For example, I have patients, even very young individuals with Parkinson's disease, tell me that one of their very first symptoms was that things would smell like they're burning, even though they know that nothing is, or a very foul odor. So that is an example of an olfactory hallucination. One other thing, I just, before we go any further, I'm gonna just pause and make sure that you can all see my screen again. So just bear with me and we'll share that. Okay, so we're now, put a thumbs up if you can see my screen again.
Perfect.
Okay, wonderful. All right, thanks for the heads up there. In addition to, the visual and the sense of smell, another example of hallucination that can involve other senses is actually not just sense of, sounds or feeling like somebody's touching you, but that kind of sixth sense, just feeling like somebody is there, looking at you over your shoulder. You turn around, nobody's there. So that even a sensed presence hallucination can occur. When we talk about hallucinations, we also often will ask about illusions or misperceptions. And a great example here in Arizona is somebody sees a fire hydrant, but for a little bit there, it looks like a cactus, and then they realize it's just a fire hydrant, or vice versa. So something looks a little bit different, and then they realize that it's actually something else. One of the most common is these little dust motes or little specks may often look like insects to people, and sometimes that can be quite disturbing. Very often people will see something very briefly, like movement or a shadow out of the corner of their eye, and then they realize that nothing's really there. So that's a broad kind of spectrum of visual illusions that many people will experience, where it's not necessarily a full-on hallucination. What a hallucination is not is a nightmare. And this is where it often becomes confusing, not just for you, the patients and the family members, but even for your doctors. Because very often people will have vivid, sometimes action-packed dreams that are very disturbing, and they may actually act out the dream, and it may be hard to kind of wake them up and get them to stop. They may be, yelling, they may be moving their arms and legs around, and it seems like a hallucination, but it's really acting out of the dreams or experiencing a vivid nightmare. So that is not what we mean when we talk about a hallucination. Another example where it's sometimes hard to sort out and we really need to get more details is very often somebody will wake up in the middle of the night and say, it's time to go to work. Or they'll say, I have to let the dog out, or the dog's been dead for 10 years. They start acting on what they just dreamed about. And this is, of course, more common in people taking a lot of medication to help them sleep, or in people who have memory and thinking problems. But that's not a hallucination. That's a problem transitioning from that asleep dream state to awake. And that's super, super important when you're talking to your healthcare providers, that you clarify what you mean when you think you see a hallucination. Because if we give medications to treat that problem, thinking it's a hallucination, it could actually make that person sleep even more deeply and be even more confused when they wake up. Another thing that we talk about when moving on from hallucinations, when we're discussing Parkinson's psychosis, is delusions. Delusions are beliefs that are hard to shake that are false, meaning that other people do not share that belief and there's clear evidence to the contrary. So these are really fixed beliefs despite evidence to the contrary. Unfortunately, the delusions that people with Parkinson's are more prone to can be very disturbing, but also hard sometimes for the doctor to decide for sure whether there's evidence to the contrary or not. For example, delusions of infidelity. Sometimes it's very obvious that this is not going on, but we need to kind of get both sides of the story and sometimes have other informants before we can decide, is this really a delusion, or is there some reason why someone believes that there's infidelity present. But an example of a more dramatic one that still falls into that really common type of delusion we call paranoid delusions, belief that someone's planning something against you, or that something bad is happening to you, is a very disturbing type of delusion that doctors love to kind of throw this name around because they love to kind of show off. So they'll say, oh, she has Capgras syndrome. And in plain English, what that means is it's an imposter syndrome. Your loved one may actually accuse you of being somebody else, or believe that you've been replaced with an imposter, or some people like to use this word doppelganger. So you look like their spouse, but they don't believe that you really are. They believe you've been replaced with an imposter. And obviously that can be a very disruptive kind of delusion when it happens, because they won't let you do anything to help them, to take care of them. Another common type of delusion, again, in that paranoid spectrum, that again, we sometimes need more information to decide if it's a delusion or not, is this belief that people are planning something against the patient. So trying to put them in a nursing home. And sometimes there's a little bit of a gray area there. They, we're trying to do what's best for them, but right now nursing home is not on the list of possibilities, but they may strongly believe that you're either planning to put them in a nursing home, that you're planning to kind of change their will and take all their money from them while they're still alive. So there may be a kind of a paranoid aspect to these delusions, and certainly that's the most common type that we see. One important distinction, however, when we're talking about hallucinations and delusions due to Parkinson's disease, is we still want to make sure that these are not solely due to a medical illness or due to a medication side effect. So if somebody is taking a medication, like very strong pain medication, it's possible that they may develop hallucinations or delusions that go away when they stop that medication and then don't come back later on. So in that case, we'll take note that there was this medication side effect, but we're not necessarily saying that's due to Parkinson's. Another example is, and this is a little bit more of a gray area, if somebody is very ill in the hospital or right after a surgery, after they've had anesthesia, they may become very disoriented and they don't really know where they are or what the date is. And along with that, they may have hallucinations or delusions. In that case, we call it delirium because there's a medical condition or a recent exposure to anesthesia, so drugs that can cause delirium. And that's causing the person to be disoriented as well as to have these hallucinations and or delusions. So delirium is not necessarily strictly related to Parkinson's, but it does raise concern that the person having the delirium is at higher risk to develop hallucinations or delusions from their Parkinson's in the future. So even if they get back to normal, we're going to be watching a little more carefully for those problems in the future. So in people with Parkinson's related hallucinations and delusions, what's a little bit different from what we generally see in someone who has, say, schizophrenia or psychiatric illness is in the beginning, as this starts to develop, many people with Parkinson's are aware or can easily be reoriented to understand that these hallucinations are not real. But over time, this often can progress to the point where it's hard to tell what's real or what's not, or it's hard to reorient you. So eventually people can lose insight about their hallucinations or delusions. So that's an important distinction there. As I mentioned earlier, another big difference is the type is more often visual. So if somebody complains to you that they're constantly hearing like a ringing or a noise in the ears, that's something that can strictly be due to hearing loss. Another point I'll make is while visual hallucinations are very common in Parkinson's, another possible cause that we as neurologists have to think about is a condition where someone who has lost vision, for example, if they have cataracts in both eyes or glaucoma in both eyes or macular degeneration, someone who has very low vision can develop hallucinations where their brain starts to play tricks on them because they're not seeing well. We like to use these terms and name things after people. This is named after a doctor called Charles Bonnet, spelled Bonnet. So Charles Bonnet was the doctor that described this eye disease. So it's another thing that we may be thinking about. If someone has very early Parkinson's disease, but they have very severe hallucinations and they have very poor vision, we might actually consider this is related to vision loss, not just due to Parkinson's. Another tricky thing is in Parkinson's disease, people tend to focus, when they have these delusions, these fixed beliefs, they tend to be more in the range of paranoid. However, when we were studying new medication to try to develop a treatment for Parkinson's, one of the problems is, each doctor kind of wants their patient to do a good job. They may rate the patient a little bit differently. So when we did the research study trying to test new medication for hallucinations and delusions, we actually used telemedicine. So even back in 2012, 2013, when we were doing this study, we had a computer screen where the screen was in reality actually talking to the person. So you had somebody on the other end of the TV talking to them and asking them questions about hallucinations and delusions. So fortunately, this type of delusion is not common in Parkinson's disease. This delusion that people in the news or people on the television are talking directly to you tends to happen more in people with schizophrenia. So fortunately, that didn't confuse things, and we were able to use that telemedicine to do the study properly. And I'll come back to that in a little bit. So over time, eventually, up to 60% of people with Parkinson's will have hallucinations or delusions to some degree. This does not necessarily mean that everyone with Parkinson's or the majority of people with Parkinson's are going to lose insight about what's real and what's not. But this is a really common problem over the course of the illness of Parkinson's. One of the most important risk factors is age, as well as or shortly followed by cognitive impairment. So as people get older, when they develop Parkinson's and they're more prone to memory and thinking problems, they are also more prone to developing hallucinations or delusions. Another important problem is medications. And it's not just medications for Parkinson's, but also certain antidepressants and bladder medications that are more prone to causing hallucinations. Same thing is true with pain medications. Another important problem is these hallucinations and delusions become more common over time the longer someone has had Parkinson's. Now, we don't fully understand what causes hallucinations and delusions, but in a little bit, I'll explain some of the theories about why this develops. Again, what I mentioned before is that medication can be an important trigger that brings out hallucinations a lot earlier than you would have had them. And so the most important medications that need to be reduced first, if someone develops hallucinations or delusions, are either of these. So if your doctor is giving you trihexyphenidyl or benztropine and you have problems with hallucinations, delusions, or memory loss, it's important that you ask them about whether this medication could be changed. If they, again, most doctors are really good about listening, but if they're not and they insist this does not cause hallucinations or delusions, you should get a second opinion, because these medications are 100 times more likely to cause hallucinations or delusions than straight up carbidopa-levodopa. So it's very important that doctors carefully monitor for hallucinations, delusions, and also memory and thinking problems as side effects when prescribing these medications, even though they can be very helpful for tremors and Parkinson's. When we're reviewing the medication list and thinking about what else could be contributing to hallucinations, another important drug is selegiline. Selegiline is broken down to the drug amphetamine before it's cleared from your body. And as you know, amphetamine is a strong stimulant that could cause hallucinations. So that one also may be the next to go if we're thinking about what can we back down or switch to something less likely to worsen or cause hallucinations. Over 10% of people taking amantadine may have an increase in hallucinations. And in some cases, it's a severe increase shortly after starting that goes away once we stop amantadine. So if you have recently started amantadine and developed hallucinations, it's important that you let your healthcare provider know. Please don't make any changes to how you take your medication or about your healthcare based on anything you hear in this talk, but make sure to talk to your healthcare provider about it. Now, another category of medication, and I just caught a typo, PRAMI, so pramipexole, ropinirole, and the Nupro patch are 3 drugs in this category called dopamine agonists that can be very useful either as an initial therapy or as an add-on to levodopa in controlling tremor, muscle rigidity, even restless leg type symptoms. However, in older patients and at higher doses, they are more likely to cause hallucinations or even frank delusions. So it's very important if you develop these problems, hallucinations or delusions with these medications, you let your healthcare provider know. Other add-on therapies that may increase hallucinations include the drugs like entacapone, and even some of these brand new ones that are coming out, Neurians. We're still going to learn what our experience with opicapone or Ongentys is, because that just got approved by the FDA. But what you don't see on this list of drugs that may be reduced is carbidopa-levodopa, because if we take away that carbidopa-levodopa, we're essentially giving up and saying there's nothing else that can be done, and we're going to take away a treatment that controls all the motor symptoms of Parkinson's. So very often during hospice care, you'll see carbidopa-levodopa, Sinemet, and Rytaria being reduced, and that's okay because it helps reduce very upsetting hallucinations in someone with very, very advanced Parkinson's. But we generally don't want to take away carbidopa-levodopa from someone with earlier stage Parkinson's because of hallucinations, but rather we may talk about actually treating them. So we'll come back to that option in a moment of how we treat. What I want to talk about first is this kind of question: what causes hallucinations or delusions in Parkinson's disease? So this looks like a fancy, complicated slide. It usually makes people kind of switch to whatever else they needed to do, check their email, talk to someone in the room there. But just think about this. By the time you are diagnosed with, or your loved one is diagnosed with Parkinson's, these cells that produce dopamine down here in the brainstem that are sending that dopamine up here have been damaged enough so at least half of the nerve endings producing dopamine are lost. Sometimes 80% or more of those nerve endings are lost, at least on the side that controls your more affected arm or leg or both. However, dopamine also acts in other parts of your brain. So the reward center of the brain and the thinking part of the brain called the cortex. And so when we give you medicine that stimulates those dopamine receptors where the dopamine is working, it's not only working in the motor system, but in other parts of the brain where that medication could trigger hallucinations. So one important chemical that's contributing is dopamine. We need to be really careful, though, when we're treating hallucinations, not to give you medicine that blocks dopamine, because giving you medicine that blocks the dopamine will block the effect of your Parkinson's medication. So it won't work as well or might not work at all. And when we do that, we're essentially giving up on your care. We're basically turning off the carbidopa-levodopa. We don't want to do that just yet in most of our patients. We want them to hang in there for a long time. In addition to dopamine, another important chemical is the memory chemical that a lot of your memory enhancers boost, called acetylcholine. So when we talked earlier about medicines that are 100 times more likely to cause hallucinations and delusions, those are the drugs that block acetylcholine, what we call the anticholinergics. In people who have had memory and thinking problems, some of those individuals have dramatic improvement in their hallucinations, even delusions, when starting those memory enhancer medications like donepezil, Aricept, the Exelon, or ribostigmine patch, because they're boosting that memory chemical. So that memory chemical is also an important component in why these hallucinations and delusions may happen, because you're losing that memory chemical. Now, a third problem is in this thinking part of the brain, the cortex. It's supplied by another mood chemical called serotonin. So down here in your brain stem, there are these other little cells sending serotonin to other parts of your brain. Because you lose serotonin, that's why nearly half of our patients develop anxiety and depression problems, because their serotonin levels are low. And that's why we often prescribe antidepressants. But because you're losing serotonin, your brain tries to make up the difference, and it start making more of the part of the brain that responds to the serotonin, called serotonin receptors. And so when we talk about treatment of hallucinations and delusions, not only will we take away some medicines that might be causing hallucinations, but rather than make your movement problems worse, we might be giving medicines that don't just block dopamine, but actually block those receptors for serotonin that contribute to the hallucination. So it's a certain type of serotonin receptor that's okay to block, that won't make you depressed by blocking it, but could actually reduce the hallucinations. So as I mentioned, I put together this talk almost 10 years ago. And back then, the most common antipsychotic available that could treat hallucinations in some patients without making the movement problems worse was Seroquel, the generic name being quetiapine. That medicine is still used a lot, but it has potential serious side effects like sedation, and also worsening or causing low blood pressure standing up, orthostatic hypotension, which we've talked about in previous talks with the Movement Disorder Alliance. So that drug is tricky to use because you may improve hallucinations for some people, but make them weak and dizzy or make them sleep all the time. So it's not a really good trade-off. Clozapine was also used a lot in some clinics, but the tricky thing with clozapine is that even though it can help, it can also cause the side effects I mentioned before. In addition, it can cause a life-threatening drop in your white blood cell counts. So unless we monitor your blood counts every week, we're actually not allowed to prescribe it. So weekly blood monitoring is not an easy thing to do either. Up until a few years ago, there was no antipsychotic specifically approved anywhere in the world to treat hallucinations and delusions specifically related to Parkinson's disease. In fact, a study back in 2011 of the VA healthcare system found that 30% of American veterans with Parkinson's were being given medicines that can actually make their Parkinson's worse. I'll say that again, 30% of patients as of 9 years ago were getting medicines that make the Parkinson's worse. That's not really an acceptable state of affairs. In fact, I have had patients, and I can't go into specific details, but I've had patients that died a lot faster because their doctors prescribed this medicine, olanzapine, because it does help the hallucinations, but it makes it so that they don't move as well, even don't swallow as well, and so they die faster. And so this is not really an acceptable solution to give someone a medicine that makes them pass away specifically because you're blocking the effect of their Parkinson's medications, but that was the approach that 30% of the time was being used. If you see this medicine on the list, this doesn't mean that you absolutely can't take a very low dose of one of these medicines, but you still want to make sure that you have a conversation with your healthcare team about the risk of worsening the Parkinson's versus the benefit and why other medicines weren't appropriate in that case. And so the medicine we'll talk about in a moment, but all medicines in the antipsychotic category have a black box warning on the label that overall older patients who have a diagnosis of dementia and hallucinations and delusions who are treated with any antipsychotic are more likely to die than people who are not. We don't know yet whether the newest drug, the Newplasid, that's the new one that we'll talk about in a moment, whether that's true with Newplasid because it just hasn't been around long enough to compare it to all the others. But for now, we need to assume this is a class effect with all antipsychotics. And we need to very carefully weigh that risk that you may be at risk to pass away sooner if you're taking an antipsychotic than if you're not, particularly if you're someone who has dementia. However, the impact of hallucinations on quality of life and even being able to just be taken care of can be profound, and these hallucinations can be really upsetting. In fact, the rate of caregiver burnout and depression, as well as the rate of people being admitted to long-term care, is at least twice as high in people with hallucinations and delusions related to their Parkinson's than people without. So it's an important kind of risk versus benefit to weigh. Another important problem is that some individuals will develop severe worsening where they lose insight about the hallucinations and can't tell whether they're real or not whenever they have an infection. And it can be with a bladder infection and happen every time they have a bladder infection, a skin infection, the flu, a cold even. And so that keeps happening. That may be a reason to treat proactively, particularly if there was very severe worsening with a particular infection or hospital stay. Other things that we can do is, in addition to avoiding stronger pain medicines and also bladder medicines or antidepressants that are considered anticholinergics, we also will try to make sure someone gets a good night's sleep and really evaluate if someone's not sleeping well, what we can do to improve the sleep, make sure they're well rested. Try to, when we can, avoid unfamiliar environments or dim lighting, which often can bring out hallucinations and delusions. Another important approach is, sometimes if you just kind of leave things be and just acknowledge someone's experience, but not try to argue about it, that may be a better approach than to escalate and have an argument or, to actually, berate someone for talking about a cat or buying cat food for a cat that isn't there or that's already passed away. It may be better to just avoid escalating the situation. Now, I mentioned that we were involved in clinical trials back in the kind of 2012, 2013 and on time frame. I want to say that there were studies going on before that that were not successful because so many people actually did improve just by talking about the hallucinations. So those behavioral approaches, or kind of thinking about which medicines are appropriate, often work. And so when we finally did the study that proved this medication is effective, we had to only study the medication in people who did not improve just with what we call brief psychological therapy, where they have just a very brief 2-week period where they get to talk with a psychologist about how they're managing the hallucinations. And if they did not improve, then they were enrolled in the study. Otherwise, the placebo effect was so high just by being in the study that it was impossible to show that the medication worked. Once the study was designed the right way, it was shown that compared to placebo, this medication does reduce the severity of hallucinations or delusions, but that doesn't necessarily mean that they go away. And it does not necessarily mean they won't get worse over time. So those are really important caveats. You have to have very clear expectation that it may help, but it may not necessarily prevent it from getting worse in the future, and it may not make it go away completely. Another really important thing to understand with this medication is that it takes at least 2 weeks to build up to a steady level in the body. And it takes at least 4, often 6 weeks or more to see the full effect of the medication. So you absolutely cannot take this medicine for a week or two and then decide whether it's helping or not. Similarly, if you are admitted to the hospital, they will not have this medicine on the formulary. And if you don't bring it from home and make sure they give it to you from home, then once it wears off from your body, it will take at least a couple of weeks to build up in your system. So it's really important to consider bringing this medicine to the hospital to be administered, because the hallucinations, if they get worse in the hospital, may not improve again until a few weeks after restarting this medicine. Now, possible side effects, one of the important things that's not on the list is worsening of the movement problems related to Parkinson's. So this standard dose, 34 milligrams a day, did not worsen the movement problems compared to placebo. And we know in our experience with the drug that it does not. The side effects that were seen more often than a placebo were swelling in the legs, nausea, confusional state, or increased hallucinations. So if somebody starts this medicine and they actually become more confused and worse off, that may be a sign that it's not for them. However, I have a rule that I teach everyone that trains with me, and I kind of chew them out if they break the rule. Even some of my caregivers that know me well know that they've been chewed out as well. Do not change more than one thing at a time, or nobody knows what is what. So if you are taking a medicine like quetiapine or Seroquel, you stop the medicine and you start Newplasid, which is going to take 4 to 6 weeks to work, and then your hallucinations are worse, it is completely impossible for me to say, is it because you stopped one medicine or is it because you started another? Now, believe it or not, there are many doctors who still don't follow that mantra. They didn't train with me. They didn't train with someone that just taught them good common sense. But you might want to point that out. If your doctor says to stop quetiapine or Seroquel and then start Newplasid at the same time, please tell them, the Dr. Shprecher, and they'll probably webcast this so they can watch the video and email me if they disagree, said the standard of care is to wait 4 to 6 weeks after starting Newplasid before stopping Seroquel. And I can send them a copy of the paper that explains that. There are exceptions. If someone is having severe side effects from the medicine, they may need to back it down a little bit right now. But if you're tolerating it well and we're adding the Newplasid, we may need to kind of wait 4 to 6 weeks and then see, can we back off this other one? And I'll tell you, a lot of the time in my experience, and this is kind of off-label, but in my experience, many people end up needing both. So if we take this one away, they get worse, and so they need the combination. And so there are people where we may start with one and then add the other and use that combination. It's also really important that your healthcare team has your full medication list up to date. So that's why nowadays in the age of telemedicine, we'll have someone sit on the phone with you for 10 minutes and go over that list before we start the visit. Because if you only have 15 or 20 minutes with the doctor, we don't want to take 10 minutes looking for that list. But when I prescribe Newplasid, I need to know if you're taking medicine that can slow conduction through the electrical system in the heart, because combining with Newplasid or other antipsychotics can further slow that conduction. Now, another important problem is that not everyone improves enough. And that's why we still need to think about what other medicines we can back down, or whether someone has memory and thinking problems that might improve with adding a memory enhancer, which could also help the hallucinations. So this is where you need a kind of a healthcare team that's thinking together and really knows the whole story about all your different symptoms. Another approach that I sometimes will use if all of these approaches that we talked about have not helped. So we're making sure that you don't have bladder infections, your urologist has got that covered. We've considered memory enhancers, we've considered the Newplasid and the quetiapine, Seroquel. There are cases where we may have to switch to that clozapine, which we know can work, but will require weekly blood count monitoring. There is a medicine called geodone, ziprasidone, that certainly can worsen motor symptoms of Parkinson's, but at very low doses can be comparable to clozapine and might actually be better tolerated at a really low dose. So those are things that some of my patients may have seen us use, but they're not used very often. As I mentioned, when someone has very advanced dementia related to Parkinson's and they have very severe hallucinations, and those are very upsetting to them and it makes it hard to take care of them, the hospice team may need to actually back down the carbidopa, levodopa. They may need to use stronger antipsychotics than what we're usually comfortable with in someone who is not going into hospice. They may also recommend regular frequent dosing of a sedative like lorazepam or alprazolam, because if you calm someone enough, it does make them more comfortable so that they're not as upset by those hallucinations that we're no longer able to control. However, in someone who we're really trying to preserve their quality of life, if we give you a sedative, that can make you more confused and disoriented, actually worsen hallucinations. So that is not a good approach to someone who's really with it in an earlier stage of Parkinson's. And that pretty much wraps up kind of my overview. So I hope that gives you a sense that there have been some improvements, and certainly one of the important things is the standard of care has really moved away from prescribing these medicines. So these medicines generally are not considered appropriate in someone who we have not yet tried the Newplasid or the quetiapine for. And again, if your doctor disagrees with that statement, I'm happy to send them the paper from 10 years ago stating that that has been standard of care since about 2010. We are now going to kind of move to kind of the question and answer session. So I'm going to pull up the chat box and start looking through some of the questions, but I'm going to defer to our moderators also to
Absolutely.
maybe kind of go through the highlights. Which question would you like me to start with?
Well, there's been a couple of questions about delirium, and what causes, and I think you've covered some of that, but how do you determine, is it delirium or are they experiencing psychosis? Like, what's the key things to look for?
Yeah, that's a great question. So delirium is a confusional state where someone is also disoriented that is caused by medical illness or due to a strong medication like anesthesia. So delirium may happen if someone is sick with COVID. It may happen if someone has the flu, even if you have a viral illness. I mean, some of us healthy individuals have had fever dreams when we're really sick, where we really are disoriented when you have a viral illness. It can also happen in the hospital after surgery, which is it's a really big surgery, so it's a big stress on the body, particularly after general anesthesia, but even with local, if someone is more predisposed to it because of Parkinson's. So the real difference is there's a clear trigger, and there's also a sudden change in mental status where the person is more disoriented than usual. This is not simply sundowning, though, where the person on a regular basis gets more confused at night. People with dementia, or even just hallucinations, delusions without dementia, may be more prone to getting worse at night. And that's not what we're referring to with delirium.
And someone did ask, what's the difference between Lewy body dementia and Parkinsonian symptoms versus the Parkinson's with hallucinations and delusions?
Yeah, so important distinction. Lewy bodies are the hallmark of what we see in the brain of someone who had Parkinson's. So they pass away and donate their brain for research or for an autopsy. Lewy body dementia is a dementia that was present during life that is related to the Lewy bodies. And it's an umbrella term, refers to dementia with Lewy bodies or dementia that happens in someone who already had Parkinson's disease. The Parkinsonism are the movement problems, the slowness, stiffness, muscle rigidity, tremor, and balance problems that are related to low dopamine levels in the brain. And Parkinson's is the most common cause of that, but it can also occur due to other degenerative illnesses of the brain. Hallucinations are mainly seen due to people having any of those Lewy body illnesses. So dementia with Lewy bodies or Parkinson's disease, whether they have dementia or not. So when someone develops hallucinations and delusions that isn't clearly related to, again, to delirium, we may sometimes revise our diagnosis even and may change that to Parkinson's disease or dementia with Lewy bodies in someone who had a different diagnosis if the hallucinations are clearly due to the illness.
And are there treatment differences if they have dementia with Lewy bodies versus Parkinson's disease with hallucinations and delusions?
So it's a tricky question because there's a lot of debate in the medical community whether there's a clear distinction or whether this is a spectrum disease. Clearly, people who have cognitive decline, so very serious memory and thinking problems to the point where they interfere with everyday activities, and we call it dementia, in the first few years of their illness, tend to have a more aggressive course of their illness. If it's in the very first year of illness that they have dementia, and they also have the Parkinsonian motor symptoms, we'll call it dementia with Lewy bodies. But if it's in the second or third year, we may call it with Parkinson's with dementia, but it's still on that more aggressive end of the spectrum. And one of the key things that we often see is those memory enhancers that boost the memory chemical, acetylcholine, like donepezil, Aricept, the Exelon or ribostigmine patch, may be more likely to help those individuals, not just with memory and thinking problems, but even hallucinations or delusions or acting out of the dreams. So that's a distinction from Alzheimer's dementia, where people may even respond better to those memory enhancers. So that's one distinction there.
Wonderful. One person sent me a private question, says specifically pertaining to paranoid delusions and finding that dopamine sweet spot with a high functioning patient of PD of 22 years. Is there a detailed standard of practice out there to reassess medications? I heard the doc talk about some drugs, was looking for his suggestion regarding a link or a journal or some resources for them maybe to share with their doctor.
Yeah, that's a tricky thing. We do need a little bit more in the terms of practice guidelines about the art of medicine in managing not just hallucinations and delusions, but many of the non-motor symptoms. And so I think that's an important need in the field, is to have good textbooks for clinicians, healthcare providers, so that they can better manage these problems. I think the best approach is to make sure that you're seeing someone whose specialty and focus is in Parkinson's and movement disorders. And generally that's someone who's done extra training beyond their 4 years of neurology residency, 4 years med school, 4 years college, so another year or two of fellowship training. So they generally have 14 years of training rather than 12. Okay, so I would say that each specialist still has slightly different approaches. So it's really important to make clear to them the time frame of when things got worse, and make sure that they're clear about all the non-motor symptoms and how they interfere with your everyday experience and your quality of life. I will say we've had a recent uptick. I don't know if it's just coincidental or kind of the flavor of the summer or the month, but we've had an uptick recently of some cases in our clinic that were very challenging, where people who were just taking straight up carbidopa, levodopa were still developing upsetting, bothersome hallucinations from the levodopa alone. And what we find is there is, yes, a sweet spot where if we can very carefully dial down the dose to one that controls the movement problems, but without triggering increased hallucinations, we can sometimes get it under control, even if the antipsychotic medicine is not helping enough. On the flip side, in my experience, I've also had people where those medicines I talked about before that are more likely to bring out hallucinations, like those dopamine agonists, when I reduce those medicines, the movement problems get worse, but then prescribing a medicine to control hallucinations allows someone to continue the medicine that was working for the motor symptoms. So there's really a clinical experience that someone needs to accumulate. And I'll say, when I look back at how I practiced in my first few years, so I've been in practice since 2009, when I put that slide deck together, thinking back, I think I have a more comprehensive approach than I did 10 years ago. So someone who's been in practice for a few years will have better honed that art of medicine than someone who's just starting out, or their first year out of training. And that's something that I think there's no substitute for clinical experience, and there's also no substitute for that additional subspecialty training. There's really an art to medicine that cannot be taught from any textbook.
Awesome. All right, so there's been a couple of questions also in regards to experience. So one person asked, is a sense that something is moving considered a hallucination? And then the other one, I'll give you both, was talking about their experience with their loved one is that they believed that they were time traveling.
So start with the sense of moving. That sense that you're moving can sometimes be other things. Some people, when they move their eyes, they actually feel like they're moving around. Some people, when they move their head, they feel like they're moving around. And so there can also be inner ear problems or other problems in the nervous system that cause this. So that's something where you have to kind of bring it up with the neurologist, but they may refer you for other testing to decide if that sense that you're moving is really a hallucination. I would kind of think of other things, though, than just hallucination with that. We've had some really interesting descriptions of hallucinations or delusions. Sense of time travel is a new one that I haven't heard. Alien abduction, however, is one that we actually have heard about more often, and people who have narcolepsy have these hallucinations when they first are falling asleep or when they first wake up, where they may feel like they've been abducted by aliens. So, out-of-body experiences, time travel, alien abduction. I'm not trying to say there isn't a conspiracy theory that isn't true out there, but some of what's been described out there with those kind of bizarre phenomena could be hallucinations. I think it would be interesting to try to compile some of those outliers, the really unusual ones like what you just described, and see how often do they really happen. But that would be a new one for me. No one's told me yet that they felt like they were a time traveler.
So that kind of leads to another really good question. This person says, I've heard hallucinations are more upsetting to the care partner than the person with Parkinson's. What are your thoughts on this? And then I think I have another question that will follow that.
Hmm. Yeah, so we don't need to treat a symptom just because it's there. So if someone sees that their family member is there and they're not really there, they see their children or pets in the room that they don't really have, but it's not upsetting, and they haven't had any issues with getting worse when they're sick, then that's something where, remember when we talked about that there is a theoretical risk of increased risk of death in prescribing an antipsychotic. So that's where I think I'd be hard pressed to say if they're actually kind of benign hallucinations, or they actually enjoy seeing the children visit. I'm not so sure I'd recommend medicine in that scenario. However, many people are more disturbed by the hallucinations than the caregivers, or the caregivers are really worried about them because they get so upset by the hallucinations. So that's a good example where I think the benefit versus the risk is in favor of making changes to the treatment plan, even prescribing medicine, in someone who clearly is upset by the hallucinations. Another example that's a gray area is where there are frequent arguments about it. One where it's not a clear distinction is if you've actually had the police come to your house because your loved one has called 911 because of the hallucinations and it's happening more than once, that's probably a wake-up call that you're overdue to address this. And I've definitely had people end up in the emergency room because the police show up to their house because they've called 911 and there's no one really to address the issue. If there is no caregiver, they end up in the emergency room and then have medication changes made because of that.
It's very complex. So I know I've talked with a lot of care partners who have loved ones, and their hallucinations and even their delusions aren't necessarily upsetting, but they can be difficult to manage because of the behaviors that occur. They might think that there's, people visiting and they're filling the room and they don't have anywhere to sit, or they get up in the middle of the night and start making food for people that are not there. The care partners are, worried, they're losing sleep. It's very stressful. Do you have any recommendations for them in regards to managing some of these behaviors?
Yeah, I mean, the first thing is it's very important that that is something that you're discussing with someone who's really skilled in managing Parkinson's and the non-motor symptoms of Parkinson's, because the management, as we talked about, is really complex. And so there are a number of changes or medicines that might be considered, but that needs to be made in consultation. That decision needs to be made in consultation with the right healthcare provider. It's true, though, that when someone's in an unfamiliar setting, if they've had a lot of sedating medication, they may be more prone to getting confused, particularly pain medicines. Also, dim lighting during the evening time may make them more prone to these hallucinations. So still having good lighting during the time that they're supposed to be awake. And then also trying to minimize the napping. I know that's not always possible, but so that they sleep more through the night and they're not up interacting with the hallucinations as much. But it's a really complex problem that you really need to individualize your approach to that.
And someone did ask about the use of melatonin for Parkinson's. Is there any negative impacts on that in terms of hallucinations?
There aren't clear negative impacts at moderate doses of melatonin. It's a medicine that has often been prescribed or recommended as over the counter to calm the acting out of dreams due to Parkinson's. It may lose some of its benefits as a sleep aid over time if it's used regularly, though. But certainly kind of the upper limit of what has been studied or what is recommended if we're using it just to calm acting out of dreams is 15 milligrams a night. So if you're going way above 15 milligrams a night, all bets are off, and it could cause other side effects, including being too tired or confusion.
Okay. And we've had quite a few people that have mentioned that they've, loved ones have used Newplasid. They've had really good response to it. And then someone asked if there was anything in the pipeline that that will benefit delusions and hallucinations. And I'm wondering if they meant aside from Newplasid.
Yeah, so from what I understand, there are several medications in the pipeline. I'm not able to speak at length about any particular ones in development. I think the website clinicaltrials.gov is really your best resource if you want to search, just search Parkinson's psychosis on clinicaltrials.gov, and you can see any drug that's in development in the United States will have a listing.
That's awesome. And we'll put that link up in the chat. Don't know if there were any other questions. Did you have anything else that you wanted to maybe state to our audience today before we finish up?
Yeah, another question that came through was about slides. So I can share a handout version with you that you can circulate or post on the website. I know that it's hard to take notes with all this information going through, so we'll try and provide the copy for you.
And one last question, because we have just a couple minutes. I think you touched on this earlier. My husband sees a woman with my name and we both have the same name and look the same. So this would be that Capgras syndrome, maybe, the imposter syndrome.
Yeah, that's an example of this imposter syndrome. So it's a delusion. And it can be a challenging problem if it does not respond to those treatments that we talked about earlier. Again, we have some people where they have not responded to or tolerated the quetiapine, Seroquel, or even responded with a combination with Newplasid, where we may switch to that clozapine in some cases, or even use other antipsychotics that are generally not recommended, but at very low doses could be tolerated.
Awesome. All right. Well, I think that's pretty much all we have time for today. Dr. Shprecher, I thank you so much for taking the time. This was such a very helpful conversation. A lot of people are dealing with this. I know there's a lot of people that have interest in this subject. It's very complex, it sounds like. We mirror that recommendation to reach out to a movement disorder specialist if you are experiencing these issues and are not having resolution of them. So as we end today, we always like to do our goodbye wave to everyone. You all have been wonderful with all of your questions. Thank you again, Dr. Shprecher, for joining us. You
Okay.
guys, thank you. The video recording will be up later on, maybe by tonight or tomorrow, so you can check it out again. Thank you so much. Bye-bye.